Are they good to go?
Yes, sir. Okay. Good evening, everyone, and I welcome everyone to the today's RSCP webinar. It will be a very interesting session, and with the permission from the President RSCP, I would like to invite the hosts to start the program for today evening.
A
Please
very
go
good
ahead.
evening to very good evening, sir.
Please go ahead.
A very good evening to all the distinguished guests, all the faculty members, respected members of RSACP Society, and all my esteemed colleagues. I am Dr. Neha Kumar, Associate Professor, Department of Anesthesia, GSVM Medical College, Kanpur, and today's webinar moderator. It is both an honor and a privilege to welcome you all to this highly anticipated CME event. It is our great honor to welcome a distinguished leader in our field, Dr. Naveen Malhotra, sir, President RSACP National, and also the webinar patron of today's CME. As President National of RSACP, Dr. Naveen Malhotra, sir, has been instrumental in shaping the future of our field in anesthesia, critical care, and especially pain medicine. He has dedicated his career in pain interventional medicine, improving patient outcome. I warmly welcome you, sir. It is
Thank you,
our
Dr. Neha.
privilege to it is our privilege to welcome Dr. Vishal Singla, sir, Honorary Secretary, RSACP National, and also patron of today's CME event. Dr. Vishal Singla, sir, is a renowned expert in the field of anesthesia. He has made significant strides in our field under his visionary leadership. As a respected leader in our field, he brings a wealth of knowledge and experience to our gathering today. Please welcome, sir. We are truly delighted to welcome Dr. Anil Verma, sir, President RSACP State and also webinar coordinator of today's event. He is someone whose leadership has been both visionary and transformative. He is widely recognized for his unwavering commitment in our field. Please welcome, sir.
Thank you very much, Dr. Neha.
Yes, sir. Today, we are not only going to expand our knowledge and skills, but also going to engage in meaningful discussion that can shape the future of healthcare. As we embark on this journey of knowledge, from our President RSACP National, Dr. Naveen Malhotra, sir. Sir, kindly bless us with your words.
Thank you, Dr. Neha, for such nice words. I don't know whether I deserve that or not, but
Sir,
so nice of you. And wish you all a very happy New Year 2025. And
thank you, sir.
from bottom of my heart, I wish and pray that all the delegates' cherished dreams come true, and there is happiness and good health uh, in all the members of your family. And may the 2025 be year of academics, clinics, and research as we are celebrating 40 years of formation of RSACP. And I'm very thrilled and excited that we have got two important topics under the leadership of Dr. Anil Kumar Verma, the National GC member of Research Society of Anesthesiology Clinical Pharmacology. And this gives me an opportunity to be here with the organizing committee of RSSP Kanpur branch because they did a magnificent CME in 2024. And I was supposed to be there, but I couldn't be there at last moment of time. And today I'll try to compensate for that. Best wishes to the speakers and delegates. Over to you. Thank you very much.
Thank you so much, sir. Now I request our Honorary Secretary, RSACP National, Dr. Vishal Singla, sir, to please bless us with few words.
Yeah,
Neha,
Dr.
Dr. Swati will take over in absence of Vishal, and the Joint Secretary will take care of the Secretary. Over to you, Swati, for your comments.
Thank you, sir, and thank you very much. Dr. Vishal Singla could not be here, and I bring his best wishes. And RCP as a society is having the foremost motto of encouraging academics, clinics, and improving practices overall and in research as well. So I must congratulate Team Kanpur for crafting a very nice program with this webinar and wish everyone participating in this webinar a very happy new year and best wishes for them and their families. And I wish all the participants in this webinar a very fruitful academic event, and I hope this will help improve and enhance the practices in the respective fields. Thank you and best wishes.
Thank you so much, ma'am, for your kind words. Now I request Dr. Anil Verma, sir, to please speak few words.
Good evening to all, and warm greetings from my side regarding New Year. And definitely, it is really an honor to be the part of such CME and under leadership of Naveen sir, because whatever we can do, that is always by the guidance of Naveen sir and his great blessings to we people. And just in continuation of those blessings, we got this opportunity to conduct this seminar and webinar, and definitely Neha would be an instrumental moderator for this webinar. And my two speakers from UP, one is Dr. Sanjeev and Dr. Bhavna. So I wish you good luck for conduction of this seminar, and may it be a great success and good knowledgeable content would be there for the participants. Thank you.
Thank you, sir. In today's session, we'll be dealing with the role of electrolytes like potassium and magnesium in our day-to-day life. In critically ill patients, imbalances in potassium levels and magnesium levels can lead to life-threatening complications. Magnesium is generally considered an underappreciated electrolyte. Hence, understanding how to manage these electrolytes in critical care settings is essential for ensuring patient safety and recovery. To start with the first session, I would like to invite and welcome Dr. Gauri Arora ma'am to moderate this session. Dr. Gauri Arora ma'am is consultant anesthesiologist and director of Arora Hospital, Nagpur. Her field of interest is regional anesthesia, pediatric anesthesia, and anesthesia for laparoscopic surgeries. Please welcome ma'am.
Thank you.
I would like to also welcome and invite Dr. Reema Meena ma'am to moderate this session. Dr. Meena ma'am is Senior Professor, Department of Anesthesiology, SMS Medical College, Jaipur. Please welcome ma'am. Our speaker of this session will be Dr. Bhavna Rastogi ma'am. She is Professor and Head, Department of Anesthesia and Critical Care, Subharti Medical College, Meerut. Dr. Bhavna Rastogi ma'am will give a talk on the topic Magnesium, a supportive and multifaceted electrolyte. I request Dr. Gauri ma'am and Dr. Reema ma'am to please start the session.
A very good evening to all of you, and I wish you all a very happy new year. I would like to thank RSACP for giving me this opportunity to chair this important session. Magnesium, a supportive and multifaceted electrolyte. Well, magnesium plays a crucial role in anesthesia and critical care because of its diverse physiological effects and their therapeutic applications. Due to its membrane stabilizing effect, like the cardiac muscle membrane, the neuromuscular membrane, its vasodilatory effect, the bronchodilatory effect, it becomes a useful element in the preoperative, intraoperative, and in the postoperative period also. And a magnesium sulfate rather serves as an adjunct in anesthesia because it offers many advantages, many benefits like analgesia and for enhancement of the neuromuscular blockade or for hemodynamic stability. So let us know more from our esteemed speaker. So I would like to welcome the speaker. Please take over.
Thank you, ma'am. Thank you so much. At the offset, I will really like to thank Anil Verma sir to give me opportunity to speak before such eminent people. I am little nervous also. I'll start my presentation. Magnesium. Magnesium is essential for human life. It plays a fundamental role in many cellular functions such as storage, metabolism, and energy utilization. It is cofactor for more than 300 enzymes in the body. It is the fourth most abundant cation in the body and second most abundant intracellular cation after potassium. Physiological properties and hemostasis of magnesium. In a 70 kg adult body, approximately 25 grams of magnesium is present. out of which 55% resides in skeleton, and 44 in soft tissue, including muscles. And that 1% is extracellular fluid. 1/4 of the magnesium in bones and muscle is exchangeable, thought to serve as reservoir for maintaining extracellular magnesium concentration. The extracellular magnesium is present from gastrointestinal absorption, renal excretion, exchangeable bone magnesium. It is around 33% bound to proteins, 60% is ionized, and 7% is bound to other anions. Total magnesium concentration ranges from 0.7 to 1 millimole or 1.7 to 2.4 milligram per deciliter. Within the cell, it is bound to protein and negatively 80% of the cytosolic numerous enzymes. Nucleus, mitochondria, endoplasmic reticulum contains a significant amount of magnesium. The recommended daily allowance of magnesium is 4.5 mg per kg, and that is approximately 250 to 350 mg for a 70 kg adult. An additional 100 mg to 150 mg is required in children, pregnant females, and nursing women. The requirement also increases in illnesses for senior citizens, in physical and mental work, like in athletes, in heart patients who are on diuretics, on digitalis therapy, during slimming and other diets, and also in diabetics. Regulation of magnesium handle. Magnesium homeostasis is influenced by dietary intake. If there is more in the load of magnesium, more will be absorbed, and vice versa. If dietary calcium is deficient, then there will be increased absorption. This is probably because of common transport mechanism of both the ions, calcium and magnesium. High protein intake increases absorption, whereas fatty acids, phytates, and phosphates decreases the absorption. Effective renal and intestinal conservation. Low magnesium intake increases absorption in intestine and reduces renal excretion. If there is increased calcium, dietary calcium, then urinary excretion of magnesium will increase. In alcoholics, urinary excretion increases, leading to deficiency of magnesium in chronic alcoholics. If there is hurried bowel or damaged mucosal state, absorption will be decreased. There are various hormonal factors which affects magnesium absorption and cellular uptake. Like parathyroid hormone and vitamin D, they all increase the absorption and renal reabsorption. And growth hormone also increases. Antidiuretic hormone and aldosterone, they increase the magnesium renal excretion. Insulin increases the cellular reuptake. Glucagon increases renal absorption. Whereas in thyroid, 80% greater excretion occur if a patient is hyperthyroid. Alkalosis increases magnesium excretion. Hypokalemia and hypercalcemia can reduce magnesium reabsorption. How the intestine and kidney handles the magnesium. Intestinal handling of magnesium mostly occurs in small intestine through two primary mechanisms. That is mainly paracellular transport, which occurs in jejunum and ileum. This occurs through the intestinal epithelial cells, which have tight junction. This depends upon the concentration of magnesium in intestinal lumen. This is a non-saturable mechanism, meaning it will increase if the magnesium intake is increasing. Another means of transport is transcellular, which is a minor pathway, which occurs in distal small intestine and colon. It occurs through the TRPM6 and TRPM7 channels, and also with the help of sodium-magnesium exchanger or transporters. It is a saturable pathway and tightly regulated. It increases only when magnesium levels are low. It is influenced by hormones like vitamin D. Renal handling of magnesium. Magnesium is filtered in kidney around 70 to 80%, but it is reabsorbed around 95 to 97%. In proximal tubule, it is around 15 to 20% by, again, paracellular means. And in thick ascending limb of loop of Henle, around 60 to 70% through sodium-potassium co-transporter, and due to presence of claudine 16 and claudine 19 paracellular transport. This is very sensitive in maintaining magnesium balance, and mutation in these tight junction proteins, that is claudin 16 and 19, can lead to renal magnesium wasting. And another left 5 to 10% occurs in distal convoluted tubule. The expression of TRMP6 is increased in by magnesium deficiency and epidermal growth factor and estrogen. After reabsorption comes the excretion. Only 3 to 5% of filtered magnesium is excreted in urine. Kidney adjusts the magnesium excretion based on the serum magnesium levels, dietary intake, and hormonal regulations. Now, what are the functions of magnesium? The magnesium has main functions on all over the body: bone structure, energy production, DNA, RNA synthesis, glutathione synthesis, blood sugar control, blood pressure regulation, muscle contraction, nerve function, essential for regular heartbeat, regulating of heartbeats. What is the cellular physiological properties of magnesium? Magnesium, as ma'am rightly said, its main action is on membrane. It has a membrane stability properties due to its attachment with the negatively charged phospholipids, stabilizing the membrane, and also with the phosphate bindings, it maintains the integrity of the lipid bilayer. It has effect on ion channel modulation, mainly regulates the opening and closing of ion channels present in membranes like calcium, potassium, and sodium. So it acts as a gatekeeper by preventing excessive ion fluxes, thus maintaining cellular homeostasis and preventing excitotoxicity. It has action on membrane pumps like sodium potassium ATPase pump, calcium ATPase pump. These are the pumps which are critical for maintaining ionic gradients and cellular homeostasis, and involved in transmembrane ion exchanges during depolarization, repolarization. These pumps also inhibits excessive calcium influx and helps to maintain low cytosolic calcium levels. Role of magnesium in these pumps is it is required as cofactor in ATP hydrolysis, which provides energy for these pumps operation. Magnesium binds to ATP and facilitate interaction with these pumps, enabling conformational changes necessary for ion transport. Thus, if there is deficiency of magnesium, these pumps will get impaired, leading to increased sodium concentration and calcium concentration inside the cell and decreased concentration of potassium. Another pumps are magnesium dependent transporters, which are important to maintain intracellular magnesium levels, and hydrogen potassium ATPase pump, which is present in gastric parietal cells. For this, magnesium is required for ATP hydrolysis, and this helps in secretion of hydrogen ion into stomach and potassium uptake. Another action of magnesium is as modulator of various channels. For example, voltage-gated ion channels. It acts as a physiological blocker of NMDA receptors by preventing excessive calcium influx. It helps in regulating kinetics of various channels like opening and closing of gates of certain channels. It helps to maintain functions of calcium channel, competes with calcium in binding sites, and reduces calcium influx through voltage-gated calcium channels. Thus, it is critical for preventing overactivation of calcium-dependent pathways that can lead to cell damage or death. The pathophysiological implication of these is that if there is magnesium deficiency, this will disrupt these sodium potassium pump, calcium ATPase pump, leading to intracellular and sodium calcium accumulation, loss of potassium and magnesium from the cell, and cellular hyperexcitability and arrhythmias. And excess of magnesium can also inhibit these ion channels, leading to muscle weakness, reduced neuromuscular transmission, and bradycardia. Another physiological actions of magnesium are enzyme activation. Intracellular free magnesium is involved in many energy reactions of phosphorylation and necessary for activation of hundreds of enzymatic reactions concerning ATPs. It has cardiovascular effects like indirect effect on cardiac muscle by inhibiting calcium uptake on troponin C, influencing myocardial contractility. It inhibits release of catecholamines and directly blocks catecholamine receptors. It has direct depressant actions on myocardial and vascular smooth muscle, resulting in hypotension. It also has antiarrhythmic actions. In nervous system, it decreases release of acetylcholine at NMJ junctions by antagonizing calcium ions, causes reduced excitability of nerves. It has anticonvulsant properties and reverses cerebral vasospasm. It decreases release of acetylcholine at NMJ through its calcium channel blocking effects, involved in terminating contraction and initiating relaxation in skeletal muscle. Thus, it potentiates non-depolarizing and neuromuscular relaxant drugs. Excessive plasma concentration can also cause muscle weakness. In respiratory system, it acts as a effective bronchodilator, but does not affect respiratory drive. Respiratory failure may occur as a result of excessive muscle weakness. In gastrointestinal system, it promotes defecation via osmotic retention of fluid, and it is used as antacids. In genitourinary system, it is powerful tocolytic, decreases uterine tone and contractility, mild diuretic properties. In hematological system, platelet activity is reduced, resulting in prolonged bleeding time, and deficiency of magnesium can be associated with platelet hyperactivity, which plays a significant role in MI, preeclampsia, and eclampsia. Now, what is dysmagnesemia? It can be both hypomagnesemia and hypermagnesemia. Plasma concentration below 0.7 millimole is mild, and below 0.5 is severe hypomagnesemia. It is frequently associated in malnourished and critically ill patients, and plasma concentration are decreased after abdominal, orthopedic, or cardiac surgeries. In hypermagnesemia, when concentration is more than 3 millimole per liter, it is hypermagnesemia. It is less frequent than hypomagnesemia. Causes of hypomagnesemia are due to decreased intake, increased loss, and redistribution. Sign and symptom, mainly general sign and symptom are generalized weakness, anorexia, apathy. Neuromuscular sign are they causes fasciculation, cramps, tremor, tetany, generalized convulsions, and ultimately paralysis. Cardiovascular, most of times, magnesium deficiency cause cardiac arrhythmias, frequently torsades pointus, ventricular tachycardia. It can also cause hypertension, sudden death, and coronary artery vasospasm. In metabolism, it causes hypokalemia, hypocalcemia, and metabolic alkalosis. Now, what are the biochemical manifestations of hypomagnesemia? It causes hypokalemia. It causes hypokalemia through potassium wasting in the kidney. Magnesium inhibits potassium secretion in kidney by modulating renal outer medullary potassium channel, which are called ROMK. In magnesium deficiency, increased activity of these channels lead to excessive potassium excretion in urine, leading to deficiency of potassium. Another action is on sodium-potassium ATPase pump. Magnesium stabilizes this pump, which maintains the balance of sodium and potassium across the membrane. Deficiency leads to impairment of this function, resulting in potassium loss from the cell, contributing to hypokalemia. Potassium depletion in these cases cannot be resolved until magnesium levels are replenished. Another biochemical manifestation is hypocalcemia. Symptomatic hypocalcemia is seen with moderate to severe magnesium deficiency. It is because of impairment of parathyroid hormone and vitamin D activation. Magnesium is very critical for secretion of parathyroid hormone, and it is a cofactor enzyme involving activating vitamin D. Low magnesium level reduces PTH secretion, and thus leading to decreased calcium release from bones and reduced calcium reabsorption by kidney. Low magnesium levels impairs conversion of vitamin D into active form, leading to decreased calcium absorption. Combined, these effect leads to hypocalcemia. So if magnesium therapy alone can resolve this kind of hypocalcemia. Management of hypomagnesemia. Although magnesium can be given orally, this route is usually used only for maintenance, and greater amount can cause diarrhea. Intramuscular injections are painful, so IV route is preferred. Magnesium sulfate usually comes as a 50% weight by volume solution. Severe or symptomatic deficiency can be treated by 2 gram in 50 ml of 5% dextrose, giving it over 30 minutes. Chronic deficiency can be corrected with larger amounts. Causes of hypermagnesemia. It frequently occurs in chronic renal insufficiency during rhabdomyolysis or excessive use of antacids. Hypermagnesemia is also observed during therapeutic administration of magnesium sulfate, usually in treatment of eclampsia. Sign and symptom of hypermagnesemia are flushing, nausea, vomiting. And in CNS, somnolence to deep coma, deep tendon reflexes are reduced and breathing may be decreased or even stopped. Hypotension because of peripheral vasodilation and conduction disorder, bradycardia, even cardiac arrest. These are the various levels at which the various signs and symptoms will appear. Management of hypermagnesemia needs stopping of magnesium-containing medications, infusion of calcium salts, and loop diuretics inhibit renal reabsorption. Patient with renal insufficiency or severe systemic side effects may need dialysis involving magnesium-poor fluids. Calcium levels need to be monitored. Now, after understanding its physiological effect, we need to see how it is multifaceted. That is therapeutic indication of magnesium in anesthesiology and critical care. In anesthesiology, it is used in anesthetic induction. It upturns the pressure response to laryngoscopy and intubation by decreasing catecholamine release. Plasma concentration of epinephrine and norepinephrine were markedly lower after intubation in magnesium-treated groups. Induction dose of propofol was also reduced. In perioperative analgesia, it enhances the analgesic action of already established analgesics as an adjuvant, so it is used as preemptive analgesic. Based on its antagonist property at NMDA receptor, its inhibitory properties for calcium channel, it is also used as analgesic. It can prevent induction of central sensitization due to peripheral nociception stimulation and abolishes hypersensitivity. Thus, a loading dose of 30 to 50 mg per kg followed by maintenance of 6 to 20 mg per kg per hour is used as analgesic dose until end of surgery. In obstetric anesthesia, high magnesium doses produces tocolysis and hypotensive effect in preeclampsia. It improves clinical symptoms of preeclampsia and eclampsia, primarily by systemic, cerebral, and uterine vasodilation. It increases concentration of two endogenous potent vasodilators, endothelium-derived relaxation factors, calcitonin gene-related peptides. Thus, it attenuates the circulating concentration of endothelin-1, which is a vasoconstrictor. And we all know there are many regimes on obstetric, like Pichard regime, Juspan regime, and Sibai regime. In surgery for pheochromocytoma, it is used in this surgery to maintain hemodynamic stability starting during intubation, intraoperatively during tumor excision, and managing pheochromocytoma site crisis. It inhibits catecholamine release from adrenal medulla and peripheral adrenergic nerve endings. It directly blocks catecholamine receptors. It has anti-arrhythmic properties due to calcium antagonism. Initial bolus of 40 to 60 mg per kg IV followed by 2 gram per hour has been suggested regime. In cardiac surgery, it is prophylactic administration of magnesium after CABG decreases incidence of atrial fibrillation. Significant decrease in ventricular dysarrhythmias and significant increase of postoperative cardiac indices is seen after usage of magnesium. Magnesium and cardioprotection. It is used as cardioprotective agent during acute myocardial infarction because it causes coronary and systemic vasodilation. It decreases myocardial membrane excitability and attenuates the incidence of infarction-related arrhythmias. Its effects on endothelium are due to increased prostaglandin I2 secretion and increased nitric oxide release. And effect on smooth muscle is due to calcium antagonism, decreased calcium release from sarcoplasmic reticulum. Cardiac arrhythmias. Being an endogenous cardiac antagonist, it slows the electrical activity of sinoatrial node, prolongs atrioventricular conduction, and increases the refractory period of atrioventricular node. So hence it is used in Torsady pointers, digoxin-induced arrhythmias, in atrial fibrillation and ventricular arrhythmias after cardiac and thoracic surgeries. It also helps in pulmonary hypertension. Being potent vasodilator has potential to reduce high pulmonary arterial pressure associated with persistent pulmonary artery hypertension. In cardiac arrest, although it has no effect on return of spontaneous circulation, but may provide cerebral protection in survived patient. In bronchial asthma, IV magnesium sulfate is useful therapy for refractory asthma. Nebulized inhalational magnesium sulfate, in addition to beta-2 agonist, is used in treatment of acute exacerbation of asthma. It improves pulmonary function. It acts as bronchodilator through attenuation of calcium-induced muscle contractions, inhibition of cholinergic neuromuscular transmission through anti-inflammatory activities, potentiation of beta agonists by increasing cyclic AMP, and mast cell stabilization. Magnesium has role in neuroprotection. In addition to an NMDA antagonist, it protects neurons and glial cell by inhibiting ischemia-induced glutamate release and calcium-dependent enzyme, and prevention of cellular apoptosis, preventing ischemic penumbra. So its use in stroke is early recovery is seen in 42% of patients, and good 90-day global function outcome in 75% who are 75% of the patient who are treated with IV magnesium sulfate. In carotid surgery, it significantly improved neurocognitive function on post-operative day 1 compared to placebo. In subarachnoid hemorrhage, as an adjuvant to nimodipine, it reduced delayed cerebral ischemia by 34% and subsequently decreased poor outcome by 23%. In spinal cord injury, it has proven neuroprotective potential in prevention of secondary injury after spinal cord trauma. It is used to control shivering, maybe due to blocking of NMDA receptor, leading to decrease in norepinephrine and 5-HT, as both of these have role in thermoregulatory control. It is even used in management of tetanus, as it reduces spasm and autonomic instability in tetanus. A proposed regime for the management of tetanus is 5 gram magnesium sulfate IV over 20 minutes, followed by 2 gram per hour IV. It can be increased by 0.5 gram per hour until there is relief of spasm or loss of patellar reflexes. Magnesium and insulin resistance. Magnesium regulates cellular glucose metabolism directly because it serves as an important cofactor for various enzymes and act as second messenger for insulin. Hypomagnesemia may induce altered cellular glucose transport, reduced pancreatic insulin secretion, defective post-receptor insulin signaling, and altered insulin-insulin receptor interaction, thus aggravating insulin resistance. Thus, magnesium, as we can see, affects whole body. In short, magnesium is fundamental to numerous physiological processes. It is essential for maintaining levels of other electrolytes. There is established indication for magnesium in treatment of eclampsia, cardiac dysarrhythmias, acute severe asthma, and prevention of adrenergic surge in pheochromocytoma surgery. Few novel applications of magnesium are in prevention of perioperative complication, post-operative pain and arrhythmia following cardiac surgeries. Hence, magnesium is often overlooked as an electrolyte which deserves a greater appreciation. Thank you.
Thank you, ma'am.
Thank you, Dr. Bhavna. It was really a very nice presentation covering each and every aspect of magnesium. I think just a short comment. There are also certain studies regarding its role in decreasing the emergence agitation in pediatric cases, and also its antenatal use has some effect in reducing the chances of cerebral palsy in premature
babies.
yeah.
Yes, ma'am. Yes, ma'am.
Okay. Dr. Gauri, you can go through there are some questions in the chat box.
Yeah, there are few questions.
Yeah, and certain comments also.
Comments also, yes.
Yeah.
This is one comment from Dr. Ajay Gupta.
Ajay.
Yeah. Up to 50% of an IV dose of magnesium may be excreted in the urine due to variability in renal function in critically ill patients. What is the protocol for follow-up magnesium level to check the replenishment of magnesium? This question is there in the chat box.
Protocol for, ma'am?
Protocol for follow-up magnesium level to check the replenishment of magnesium. Up to 50% of the IV dose that we give it may be
Yeah.
excreted in the urine.
Ma'am, magnesium levels need to be checked repeatedly in ICU if they are given IV.
Okay. Repeatedly, at what intervals? Hello?
Hello.
Yeah. Any specific interval it should be checked for or anything?
I'm sorry, I cannot.
Okay. There's another question. Most patients with clinically significant hypomagnesemia should receive 1 to 2 grams given over an hour, followed by 4 to 8 grams given slowly over 12 to 24 hours. Any comments? Okay. Any association between serum magnesium and pathophysiology of sepsis?
Ma'am, recent studies have commented that it increases, it affects the immunity levels. And there are recent studies which says that it has some role in sepsis because it increases levels of interleukin-6 and TNF-alpha. It acts as a co-factor in synthesis of thymine pyrophosphate, which is produced in gastric acid. So it can cause infections through GI tract. It is also a cofactor in Krebs cycle, impairs ATP production. So it can lead to metabolic, anaerobic metabolism and leading to lactic acidosis. In recent article I have gone through, there are some articles which says that magnesium does have some role in sepsis. So hypomagnesia, magnesium, if it is there, then sepsis load can increase through GI infections. There is an article on this available.
Okay. And what about septic coagulopathy? Is there any association between
Ma'am, there is that it affects the platelet functions. So if there is hypomagnesemia, then platelet functions can get more deranged and that can lead to coagulopathy. There is some article available on this also. But there is no definitive, like it is still a matter of research. There is no definitive any.
Okay. So I think that answers Dr. Gupta's question. There's another question from Dr. Kamlakar Pawar. How to use magnesium sulfate in nebulization? Which preparation and what dosage?
Ma'am, it is used there is a article which is saying it is the same preparation, magnesium sulfate. It is used in a dose of 50 milligram dose, which is used. There are n number of articles, although I have not checked the effective dose, but it is used. They are saying up to 50 milligram to 2 gram can be used for nebulization for prevention, like for dealing with bronchodilation.
Okay. And how long magnesium sulfate is to be continued in eclamptic patients, especially if there are recurrent seizures?
Ma'am, it has to be continued. We do monitor generally the obstetrician or continue it till till they get a relief, until
That's okay. I think
Hello, it's
they are,
okay.
yeah. Till there is no other any side effect, no toxicity is there, and they get relief for the baby's delivery. It's okay. And there are many more comments, but I think everybody can go through it. These are more like
Yes.
comments. So if there is no any other question from the audience, otherwise we can move on to the next. Yeah.
No, one thing I want to ask.
Yes,
What
please.
kind of monitoring is required if you are giving an magnesium infusion? Hello?
Can you repeat?
I said, what kind of monitoring is required in the intraoperative period if you are giving magnesium infusion?
Ma'am, we need to check levels of magnesium if we are continuing it. Like
Okay.
that they are in normal range, we can send ABG. Many a times it is available. So
Okay.
if they are in normal range, then there is no fear. Like we can continue to use infusion intraoperative.
Okay. They potentiate neuromuscular blockade. So would you like
Yeah,
to monitor neuromuscular monitoring?
ma'am,
Would you
yes.
like to do that?
Hi, yes, it is done. If we are using, like
Yeah.
in neuro, we do use it. So we are having neuromuscular monitoring is there, and muscle relaxant doses are decreased according to the need of after monitoring. If magnesium sulfate is used, neuromuscular monitoring is definitely done. It is done even in our setup also.
Okay. And how long before the reversal would you like to stop your magnesium infusion? Will it interfere with the reversal?
Ma'am, it
And in
will.
fact, with the dosages also of the reversal drugs like neostigmine or sugammadex, in fact.
Yeah, it will. We need to stop it with at least half an hour before, if
Correct.
the surgery is going to end. It has to be stopped half an hour before the end of the surgery. And definitely, if it continues, it may interfere. We may need more doses, and it may delay the reversal.
Okay. And will it reduce the fasciculations of scoline, or say the rigidity that we see with ketamine? Is it going to have some effect? Use of
Ma'am, this is a personal. I haven't used it. I have never seen that. But yeah, with the activity, with the actions, physiological property, it may definitely reduce fasciculations. Although I have not personally experienced, neither I have seen it, but it may help in reducing fasciculations of schooling.
Okay. And if we use it with local anesthetics for our, say, spinal, epidural, or the peripheral blocks, is it going to potentiate this?
It is in few articles they are there which says it is used as adjuvant with local anesthetic, and it enhance its action is there on NMDA receptors, so it enhance the duration of analgesia after spinal. There are few articles available on this also, both in spinal and in epidural, and its action is through NMDA receptors on dorsal horn. So its action is there, and it potentiates the analgesia, duration of analgesia.
Okay. And if we want to reduce the stress response of laryngoscopy
Yeah,
and
it is.
intubation,
Yeah, it is used.
so when should is the right time to give the drug? When
Well,
should we start it? And how much should we give?
it is given in the dose of 50 mg per kg body weight, and it is given just before like intubation we give. With pre-medication it is given, and it is
Okay.
given in dose of 50 mg per kg.
Right. So any other question? I'll just check. I can't find any other question. So, madam, should we move on to the next topic?
Yes, please.
So thank you very much. That was a nice talk.
Thank you, ma'am.
Thank you, Dr. Bhavna Rastogi, ma'am, for the insightful and thought-provoking presentation. Thank you, Dr. Gauri Arora, ma'am, and Dr. Rima Meena, ma'am, for moderating this session. Before proceeding with the session, I would like to invite and welcome Dr. Tej K. Kaul, sir, patron RSACP. Please welcome, sir. And I request, sir, to please speak few words.
Hello, do you hear me? Do you hear me?
Yes, sir. Good evening, sir.
Yes, sir. Good evening.
Good evening, sir.
Very good evening to everybody. Thank you. Thank you all. This session has been really an excellent one. When I joined 10 minutes later, I was late by 10 minutes. There was no space left because the lecture was running to its full capacity. Then I requested Dr. Swati to just adjust me somewhere. So she adjusted me and I was there. I am highly impressed by the participation of the faculty as well as the residents for such an important topics like electrolyte imbalances in ICU, particularly about the magnesium. The speaker has been excellent. My best wishes to the organizers. Everyone has been excellent. I am very, very happy today for seeing the participation today. Thank you very much. God bless you all.
Thank you so much, sir. To start
Thank
with
you
the
for
next. Thank you, sir. To start with the next session, I would like to invite and welcome Dr. Meenu Chadda ma'am to moderate this session. Dr. Meenu ma'am is Head of Department KSCHL Hospital, Indore. I also invite and welcome Dr. Swati Chabra ma'am to moderate this session. Dr. Swati ma'am is Additional Professor in Department of Anesthesia and Critical Care at AIIMS, Jodhpur. Please welcome ma'am.
Thank you so much. Good evening, everybody.
Good
Now
evening.
we know that the next topic is on potassium, and potassium is a very important cation in the intracellular space because it plays a very essential role in maintenance of the resting membrane potential, neuromuscular function, regulation of the myocardial contractility, cellular protein synthesis, and also enzymatic functions. So it helps in maintaining, has a vital role in the body functions. But regular monitoring and replacement is very, very essential to prevent the complications. Now, let us hear all the details about potassium dyselectrolemia from the speaker.
I request Dr. O.P. Sanjeev sir to please start the talk.
Respected patron, call sir, respected President Naveen Mehrotra sir, cherished faculties from all the corners of the country, and most valued delegates, good evening, one and everyone. Now my part of the work has been made easy by the opening remark of my moderator, madam. So thank you, madam. Now I'll share my slides. I hope my slides are visible.
Okay,
yes,
yes.
they are.
Okay, thank you very much. So let's begin with the potassium dyselectrolytemia in the ICU. We used to address the potassium imbalance by naming it as potassium dyselectrolytemia, but I recently seen in a published article that the word has been little simplified and people say it dyskalemia. Dyskalemia means abnormality of the serum potassium level. So let's begin. The specific learning objectives, because I see most of the valued delegate students are attending this session, and I was truly mesmerized with the kind of discussion that followed up immediately after presentation that made me little scared too. But addressing the need of the students, I have put forward here the specific learning objectives, and the first and foremost is potassium homeostasis, followed by management of hypokalemia, that is the reduced serum potassium level, followed by the management of hyperkalemia, that is increased serum potassium level. Let's begin with the case scenario to bring more interest in the topic. A 62-year-old male resident of Basti with a known case of diabetes, mellitus, hypertension, from many years reported to emergency department with severe shortness of breath. Oxygen supplementation was initiated and patient was immediately attached to a multi-parameter. ECG shows tall T waves and heart rate of 52 per minute. A 12-lead ECG was obtained, which is as follows. So how we should approach this case? Once we listen the tall T waves, automatically we are activated and become curious to search hyperkalemia somewhere. So the provisional diagnosis, just by seeing the ECG, comes in our mind that yes, there is something related with the potassium imbalance, and most likely it is hyperkalemia. So thereafter we must make a plan. Thereafter we prepare certain medications, and we decide that where we have to seek some help from the experts or not. So beginning with the importance of potassium, that has well been described by my moderator madam in the beginning, that it is essential for the functions of many bodily functions, especially for the functions of excitable tissues like nerves, skeletal muscles, and cardiac muscles. And we all know that potassium imbalance is one of the important 5H reversible causes of cardiac arrest. So the AHA has addressed 10 reasons for the reversible causes of cardiac arrest, and amongst 5H, potassium imbalance is one of them. So if we enumerate hypoxia, hypovolemia, acidosis, that is represented by H plus ion, thereafter hypo and hyperkalemia and hyperthermia. So hypohyperkalemia is one of them. So this electrolyte imbalance actually can lead to cardiac arrest. So it is very important for us to know. Let's look at potassium distribution inside the body. An average built body, human body, contains almost 3,500 milliequivalent of potassium. That is in the range of 50 to 55 milliequivalent per kg body weight. So for a average adult male of around 70 kg, 70 multiplied by 50 comes to 3,500 milliequivalent. So this is our total potassium content of our body. 98% of potassium, as mentioned by my moderator in the beginning, is intracellular. And only 2% of the potassium is extracellular. So 2% of potassium is around 70 milliequivalent. So only 70 milliequivalent of potassium is extracellular, in extracellular fluid. We know that plasma constitutes only 1/5, around 20% of the total extracellular fluid. So the plasma has only 15 milliequivalent of potassium. So the entire plasma of an average adult human body contains only 15 milliequivalent of potassium. So only 0.4% of total body potassium is present in plasma, that is measurable in our blood tests. So serum plasma just represents the tip of the iceberg and nothing else. So out of 3,500 milliequivalent of potassium, total potassium inside body, only 15 milliequivalent is present in the plasma or in the circulating blood out of RBC. If you look at the regulation of potassium, potassium is tightly regulated by environments of blood like acidosis, alkalosis. It is slightly regulated by certain hormones like aldosterone, insulin. So if an average intake of 120 to 140 milliequivalent of potassium per day, only 10% of the ingested potassium is excreted in the fecal material. Only 10% is excreted in the fecal material. I guess I'm audible.
Yes, you are audible.
Okay, thank you. And rest 90% is excreted through kidneys. So kidney is the major excretory organ for this potassium. So 100 to 120 milliequivalent of potassium that is added to the GI tract every day. Only 10%, around 5 to 10 milliequivalent is excreted in fecal material, and rest is excreted through the kidneys. The internal potassium balance is maintained by insulin, epinephrine, or alkalosis, which tends to push the potassium inside the cells. and exercise, cellular lysis, hyperosmolarity, acidosis, which attempts to pull the potassium out of the cells. Potassium balance. I would like to request you all to please focus on this zero. This is homeostatic balance. The x-axis represents the potassium depletion or potassium excess, and the y-axis represents the serum potassium level. So just look. In case of potassium depletion, the curvilinear line is flat, almost flat. So the deficit is not going to change the serum potassium concentration much. But any excess of potassium is definitely going to change the serum potassium level very rapidly, because the graph is steeper over here. As intracellular potassium has very rich quantity of potassium, so any depletion is not going to change the serum potassium level very rapidly, but any excess is definitely going to change the serum potassium level very rapidly. And so to decrease the plasma potassium by 1 milliequivalent, there is requirement of 200 to 400 milliequivalent of potassium depletion, whereas increase of plasma potassium by 1 milliequivalent per liter requires just 100 to 200 milliequivalent excess of potassium in the blood, in the body. As I mentioned earlier, that potassium is excreted mainly by kidneys, and particularly the distal convoluted tubules DCT1 and DCT2 are responsible for potassium excretion, because in the PCT most of the secreted potassium is reabsorbed. This is here only where potassium is again secreted for excretion after maintaining the balance of the serum potassium. So this is the reason of kidney where aldosterone acts to absorb it, to excrete it, and its antagonist spironolactone acts to reabsorb it. So why spironolactone is called potassium sparing diuretic? It conserves potassium. Here is the role of magnesium, which helps to retain the potassium. And in case of hypomagnesemia, there is difficult to manage hypokalemia, because without magnesium, kidney cannot attempt to conserve potassium wastage. So this magnesium is important. Now coming to the hypokalemia, that is a clinical situation. The clinical situation where the serum potassium level is less than 3.5 milliequivalent. The normal potassium level, we all know, is 3.5 milliequivalent per liter to 5.5 milliequivalent per liter. So the causes can be broadly categorized into either there may be low intake, as in case of fasting, starvation, or prolonged order to keep the patient nil per os, as in cases of acute pancreatitis many a time. There can be transcellular shift where potassium may be pushed inside cells, and there can be serum hypokalemia. Like in case of medications like beta-2 agonist, or in case of insulin infusion, the alkalotic internal environment and hypothermia. The third component is loss. If there is loss of potassium out of body, this can again be categorized or grouped into two broad categories: renal losses and extrarenal losses. Renal losses can be due to diuretics or can be due to magnesium deficiency, and extrarenal losses can be due to either diarrhea or nasogastric tube drainage. If you look at the clinical features, yes, in case of hypokalemia, there may be some clinical features that seek our attention to look into it, but most of the hypokalemia are asymptomatic. Almost 50% hypokalemia are asymptomatic, and patients have hardly any symptoms. However, leg cramps, weakness, paralysis or ascending paralysis, constipation or intestinal paralysis, ileus or cardiac arrhythmias are some of the presentations of the hypokalemia. It is obvious to catch through ECGs, and there are many features described for both hypokalemia and hyperkalemia. In hypokalemia, there may be peaked P wave, there may be prolonged PR interval, there may be ST depression, there can be either shallow T wave or flat T wave or inverted T wave. I will again repeat this slide when I will discuss ECG changes of hyperkalemia. And there can be a prominent U wave. As T wave is flattened or inverted, U wave become little easier to pick in case of hypokalemia. Evaluation of potassium depletion due to losses. If we wish to evaluate that what is the cause of the potassium loss from the body, we need to do a spot urine potassium. If it is less than 30 milliequivalent per liter, then it is obvious that the cause of this potassium loss is diarrhea. If the serum potassium is, if the urine potassium is more than 30 milliequivalent per liter, we need to check spot urine chloride. If spot urine chloride is more than 25 milliequivalent per liter, that is, the urine is rich in potassium as well as chloride, then the cause of potassium loss is kidney, and probably diuretics or magnesium depletion is the reason. In case of rich urine with potassium but less chloride is there, the cause can be either alkalosis or nasogastric tube drainage. Nasogastric drainage has a low concentration of potassium, however, 10 to 15 milliequivalent per liter only, but the resulting loss of volume and hydrogen ion promotes potassium loss in the urine, so it does causes hypokalemia. In case of diarrhea, usually in cases of secretory and inflammatory diarrhea, the concentration of potassium in stool is too high. It is 15 to 40 milliequivalent per liter of stool passed. सो हमारे पूरे ब्लड में 10 से 15 मिली इक्विवेलेंट पोटेशियम है और 1 लीटर स्टूल में 15 to 40 millicuvalent of potassium is being wasted. So the secretory or inflammatory diarrhea leads to hypokalemia. Estimate of potassium depletion. As I mentioned earlier, that the potassium is primarily an intracellular cation, and about 10% of total body potassium is lost for every 1 milliequivalent per liter decrease in serum potassium. That is, if around 350 milliequivalent of potassium is lost, it will deflect in serum by just decrease of 1 milliequivalent per liter. And there is a beautiful table in the Paul Marino latest edition, 5th edition. The decrease of 0.1 milliequivalent per liter of serum potassium implies potassium deficit of around 35 milliequivalent. Decrease in 0.5 milliequivalent per liter of serum potassium means loss of around 175 milliequivalent of potassium. Similarly, a decrease of 1 milliequivalent of serum potassium means there is deficiency of around 350 milliequivalent of potassium. Classification of hyperkalemia can well be done on the basis of the serum potassium level, and any value that is more than 3 but less than 3.5 is mild. A value between 2.5 to 3 is moderate hypokalemia. And for severe hypokalemia, the serum potassium must be less than 2.5 milliequivalent per liter. So management is based on the mechanism. If there is shift due to either internal environment derangements, we use to correct the causes. If there is insulin infusion and this insulin is causing potassium to shift inside the body, we need to supplement the potassium. If there is true depletion of the potassium in the body, we can replenish it either with the oral preparations or with IV potassium chloride. In case of refractory hypokalemia, never forget to use magnesium, because as mentioned earlier, it helps to reabsorb potassium from the distal convoluted tubule. So medications available are, we all know that there is oral potassium chloride suspension, which contains 20 milliequivalent per 15 ml of the solution. So usually oral potassium chloride is prescribed in this range only, 15 ml BD, 15 ml TDS, because if you prescribe in the aliquots of 15 ml, it will be easier to calculate the total potassium intake of prescription. If we prescribe 10 ml TDS or 20 ml TDS, it becomes a little difficult to calculate the exact amount of the potassium content of this prescription. So it is better to prescribe 15 ml TDS, 15 ml QID, 15 ml BD, so that we can know that yes, in one dose we are giving 20 milliequivalent of potassium chloride. For IB correction, we have potassium chloride solution, which contains 2 milliequivalent of potassium per ml. And if we take the 10 ml ampule, it contains 20 milliequivalent of potassium. There are certain tricks to administer potassium. We all must be knowing it. And we know that the oral route for stable patients is preferred, and IV route must be used for severe hypokalemia. And a standard infusion rate of potassium chloride infusion is 10 milliequivalent per hour. If we need to administer higher rates like 20 milliequivalent per liter, we need to infuse either through the central venous catheter or through the 2 wide bore peripheral IV cannula, because we know that the potassium chloride solution is very irritant. It is irritant because it is hyperosmolar. Its osmolality is around 4,000. If we compare to osmolality of the blood, it is only 275 to 285. That the potassium chloride injection is the osmolality of 4,000. So it is multiple times more osmolar. So we need to give in dilution. A standard precaution is to use at least 5 times dilution, 10 ml at least 10 times dilution. Or if you wish to give undiluted, you can give it through a small infusions, a small rate of infusions, and a close monitoring with multi-param monitor and 12-day ECG must be done. In case of low magnesium, we should give 4 ml, that is 2 gram of magnesium sulfate diluted in 100 ml normal saline, and to be infused over 30 to 60 minutes. So summary of hypokalemia. Hypokalemia is not a risk for serious arrhythmias unless combined with a drug or clinical condition that can trigger arrhythmia. So hypokalemia on its own does not cause serious arrhythmias like hyperkalemia. It is relatively safer. But in case of drugs or many other clinical situations like acute coronary syndrome associated with hypokalemia, it can trigger serious arrhythmias. We need to calculate depletion carefully because just 1 milliequivalent decrease in serum potassium indicates almost 300 to 350 milliequivalent total potassium deficiency. And we should manage it with either oral or IV potassium supplementation. When hypokalemia is refractory to potassium replacement, magnesium deficiency is likely the source of the problem. And this is summary of hypokalemia, and this is not summary of my presentation. So still I have a few slides for you. So let's continue. So hyperkalemia is defined as the serum potassium level of more than 5.5 milliequivalent per liter. Again, we can categorize the causes of hyperkalemia as excessive load, as we can see in cases of massive blood transfusion or iatrogenic potassium chloride administration, or there can be transcellular shift in cases of certain drugs like beta blockers, digitalis, or our must known drug succinylcholine. The acidosis shifts the potassium out of the cells. Similarly, the tumor lysis syndrome shifts the potassium out of the cell and causes hyperkalemia, and hyperkalemia is the most dangerous electrolyte abnormality in case of tumor lysis syndrome, along with other myriad electrolyte imbalances. There can be impaired renal excretion, which can lead to hyperkalemia, as in cases of acute kidney injury or acute kidney injury on pre-existing chronic kidney disease. Many a time, the long-standing patients of chronic kidney disease presents with hyperkalemia to the emergency department as their first presentation of failure. There are certain drugs which impairs renal excretion, and the notorious ones are ACE inhibitors, angiotensin receptor blockers, amiloride, NSAIDs, spironolactone, and trimethoprim sulfamethoxazole. Blood transfusion, consistent complication of massive blood transfusion. Actually, the temperature used to store red blood cells shuts off the sodium-potassium exchange pump in the erythrocyte cell membrane, and this results in a steady leakage of potassium from the cells. After 18 days of storage, which is the average time that blood is stored, the potassium load in 1 unit of packed red blood cells is 2 to 3 milliequivalent per liter. So obviously 6 units of red blood cells that is required usually for massive blood transfusion will make 6 into 2, 12 to 18 milliequivalent of potassium load. तो अगर हम massive blood transfusion करते हैं तो we are adding 12 to 18 milliequivalent of potassium to the circulation, और प्लाज्मा का अपना जो पोटेशियम कंटेंट है दैट इज ओनली 10 to 15 मिलीक्यूवेलेंट. तो जितना उसका कंटेंट है उतना हम लोग और ऐड कर देते हैं. However, this is not that this potassium load cannot be handled by kidney. Kidney can well accommodate this potassium by excreting a lot of potassium through the kidneys in urine. But the practical situation where there is a need of massive blood transfusion, the kidneys must not be working well because it's a case of hypovolemic or hemorrhagic shock. So in case of massive blood transfusion, usually there is coexisting shock, so there is impaired renal function, and in that scenario, massive blood transfusion do cause hyperkalemia. So ECG changes of hyperkalemia are good stuff for medical students, medical teachers, because it is lovely to ask questions on ECG findings of hyperkalemia, and it is easy to answer it is also easier to answer this question. So the findings are the flattened P wave, the prolonged PR interval, widened QRS complex, which later on looks like sine wave pattern, ST segment depression, and tall tented T wave. So tall tented T wave looks like a synonym for the hyperkalemia. Whenever somebody says that tall tented T wave, we look that we are going to get a case of hyperkalemia. But in medical science, nothing fits like mathematics. So there is a close DD of tall tented T wave, and that is hyperacute myocardial infarction. In case of hyperacute myocardial infarction, again the T waves are tall. But there is some difference. The difference is that T wave of hyperkalemia has a narrow base. The base is narrow. It is symmetrical. Upstroke and downstroke, both limbs are symmetrical. And it is pointed at the top. So the T wave of hyperkalemia can prick your finger. If you put your finger over here, it will prick inside. While the T wave of STEMI, or rather better can be said as the hyperacute MI, in case of hyperacute MI, the T wave is tall, but it is not pointed. The base is not narrow. It is wide based. And it is not symmetrical. The upstroke is different and the downstroke is different. So we can differentiate between the tall T waves of hyperkalemia and hyperacute MI. There is one more method to differentiate, because in case of hyperkalemia, tall tented T waves will be everywhere in all 12 leads. But in case of hyperacute MI or STEMI, usually the T waves will not be tall and tented in all leads, until unless there is blockage of the left main coronary artery or the right coronary artery at the same time. So it is less likely. So this is how we differentiate between the tall T waves of hyperkalemia and the tall T waves of hyperacute MI. As I promised earlier, then again I will discuss the ECG changes of hypokalemia with hyperkalemia to remember easily. And this is not for most of the participants of this webinar. This is for the just few students who are in their first year of PG. This is for them only, because the rest of us are very well versed with the ECG changes of hyperkalemia and hypokalemia. So as the potassium level increases, the T wave increases. Rising potassium means rising T waves, and decreasing potassium means decreasing T wave, flattening T wave, and inverted T wave. So this is one mnemonic to remember the T-wave changes in hypo and hyperkalemia. Now, severity of hyperkalemia. As we define the severity of hypokalemia in the terms of serum potassium level, this is not exactly similar for the hyperkalemia because here ECG changes are also very important. And a serum potassium level of 5 to 6 with ECG changes is not mild, it is moderate hyperkalemia. Serum potassium level of 6.1 to 6.5 with ECG changes positive, it is severe hyperkalemia. And any potassium level that is more than 6.5 with or without ECG changes is defined as severe hyperkalemia. Just 2 or 3 slides are left. I will wind up quickly. So the management of this condition has 3 important goals. Management of hyperkalemia is very, very important and it is a true emergency. We cannot ignore and leave behind. So the first goal is blocking the effects of hyperkalemia on the cardiac conduction system. Just as my moderator, madam, mentioned earlier, that potassium is something which is related with the depolarization of the membrane. So in case of hyperkalemia, we need membrane stabilizing agent, that is calcium. Thereafter, we attempt to shift potassium back into the cells. We use insulin, we use salbutamol aerosol in nebulization. I will mention in coming slide. And thereafter, we will attempt to remove excess potassium out of the body because moving the potassium inside cell does not mean that the total potassium load of the body has been decreased. बट यहाँ का सामान वहां रख दिया है, फिर बाहर से निकल के सेल से निकल के वो ब्लड में आ सकता है. So we need to also consider the third goal, that is removing excess potassium from the body, where we use key bind sachets like calcium polystyrene sulfonate powder. So in case of acute hyperkalemia, IV calcium, IV insulin glucose, nebulized salbutamol. Thereafter, in few cases, sodium bicarbonate or diuretics or hemodialysis we use. And for removal of the excess potassium on a long-term basis, we use K-bind sachets. Now, this is the very important table, and it is probably my second last slide. I will finish very quickly. This slide is very important. We must know that calcium gluconate is the true antagonist of the hyperkalemia, but it also takes 1 to 2 minutes to act, and it acts only for 30 to 60 minutes. So if 30 to 60 minutes is passed, we need to repeat the calcium gluconate dose if serum potassium level is still high. Insulin, 10 unit regular insulin in 50 ml, 50% dextrose. The time of onset is 10 to 20 minutes. ऐसा नहीं है कि इंसुलिन ग्लूकोज देते देते वो पोटेशियम लेवल को, सीरम पोटेशियम को कम कर देगा, बिल्कुल नहीं करेगा. It takes 10 to 20 minutes, sometimes it takes 30 minutes. And the duration of action is only 2 to 6 hours. So again, after 6 hours, we need to repeat the dose. Beta agonist, albuterol. Actually, albuterol is used in America. We in India use salbutamol. Salbutamol and albuterol are both the same compound, but the name is different in different countries. The dose is important. The dose is 4 times the usual dose of bronchospasm through nebulization. We actually utilize the side effects of nebulized salbutamol to decrease potassium level. The onset of action takes 3 to 5 minutes and duration of action is only 1 to 4 hours. Exchange regimens is given, which start acting after 2 to 6 hours and duration of action is 4 to 6 hours. Sodium bicarbonate, 50 milliequivalent bolus can be given, but it is to be given only in cases of metabolic acidosis, no other indication. It is not panacea for all hyperkalemia. Furosemide, 40 to 80 mg of IV furosemide bolus can be given provided there is coexisting hypervolemia. If there is no hypervolemia, there is no furosemide. Hemodialysis. Hemodialysis is very important because it truly takes potassium out of the body, but this is not that just initiation of the hemodialysis will decrease the potassium. It takes at least 1 hour to decrease the serum potassium level by 1 milliequivalent per liter, and it takes full 3 hours to decrease the serum potassium level by 2 milliequivalent per liter. So whenever you shift a patient of hyperkalemia for hemodialysis, do not forget to stabilize the membrane. Do not forget to give calcium gluconate because it is going to give the cover of stabilizing the membrane for 30 to 60 minutes. So thereafter only potassium level will start decreasing during hemodialysis. This is not that just initiation of hemodialysis will bring your potassium down. So summary of hyperkalemia, it can be lethal, not to be ignored, not to be left behind. Calcium gluconate is an antagonist of potassium. Use it. If required, repeat it. Every 5 minutes, you can repeat up to 3 doses. The time of onset of medications must be kept in mind because this is not that we administer the drug and it will start working. Duration of action must not be missed because you need to repeat the dosage if the potassium level is not brought to the normal range. So key points are considering that only 2% of the potassium in the body is outside cells and that only 20% of the extracellular potassium is in plasma. Monitoring the plasma potassium gives us information about less than 1% of the potassium in the body. That might explain why hypokalemia is often clinically silent and why there is a poor correlation between the severity of hyperkalemia and the presence of ECG changes. Thank you very much. Hand over to my moderator.
I must congratulate the speaker, Dr. O.P. Sanjeev, for presenting a very comprehensive review of very important dyslipidemia, that of potassium. So I see some questions in the chat box and I'll take them one by one with permission from Dr. Minu Chadha.
Yes, go
Ma'am?
ahead. Go ahead. Yeah.
Yeah. Comments is to the role of measurement of urine potassium levels and the urine potassium to creatinine ratio. How does this help to differentiate between renal and non-renal causes of hypokalemia?
Actually, as far as the workup for hypokalemia is concerned, we need not to do urine potassium versus creatinine level. If there is potassium content of urine is more than 30 milliequivalent per liter, it is likely that the cause of loss of potassium is urine only. In case of hypokalemia, I don't know whether the person has asked the query, raised the query about hyperkalemia or hypokalemia.
It's about hypokalemia.
Hypokalemia, we just need to check a spot urinary potassium and chloride. And as per the algorithm, we can come out to a conclusion because we need to only to differentiate that whether the cause of loss is renal or extra-renal.
Right. And this potassium sparing diuretics for prevention as well as treatment of hypokalemia in patients with volume overload and normal renal function.
Pardon, can you repeat, please? Yes, it is used as spiroleptin. I could not listen the question correctly.
So is there any role of potassium sparing diuretics to prevent or treat hypokalemia in patients with volume overload?
Actually, in cases of chronic liver disease, potassium sparing diuretic is used frequently because such patients are usually hypervolemic and there is potassium depletion. So, at most of the time to treat the refractory ascites, diuretic is prescribed with spironolactone.
Right. And so another question regarding existence of any guidelines about the role of loop diuretics in patients who are non-oligouric.
Actually, patients who are non-oliguric means one who have the normal urine output, furosemide can be given provided there are evidence of hypervolemia. It looks that diuretic will keep the potassium out of the body, but it is not useful. It is not recommended unless until there is normal renal function and there is evidence of hypervolemia.
And what is the role of the resins in critically ill population? Talking about hyperkalemia.
Yeah, actually, critically ill patients, we used to use it because if there is excessive load of potassium inside the body, this is the way where we can take the potassium out of the body. If the patient is not hemodialysis dependent, if patient does not require hemodialysis, we can use these K binders.
Okay. And so like there are multiple questions regarding the resin. So if you could share some literature regarding the raisins, in because there is paucity of time right now. So if you could share some literature on raisins in critically ill population, we can share on the RSCP groups. That would be useful for the readers at large.
I will try to share, but I personally believe more in reading textbook rather than the literature and journals. So the latest textbook that I read do mention about multiple types of resins like calcium sulfonate and there is one zirconate, sodium zirconate resins. So these are used, they reduce the, but as the GI loss of potassium is much less, it is only 10% of the total ingested potassium every day, 5 to 10 milliequivalent per day only. So it is not going to help much, but obviously if there is potassium overload we can give, it has no side effects.
Right, makes sense. I request Dr. Minu Chadha ma'am to take any questions or make any comments on this presentation.
Excellent presentation, Dr. Sanjeev. Very lucid. You covered the whole thing so nicely and explained it very well. Just one thing I'd like to ask is how much magnesium is needed for a refractory hypokalemia patient?
But actually, I tried to search the exact dose of magnesium to treat hypokalemia. I found just one dose of magnesium sulfate, that is 2 gram, to be added in 100 ml normal saline and to be infused over 30 minutes. This is the OD dose of hypokalemia. If again next day the potassium level is less, we can repeat it.
Okay. Thank you. I think that's all, Swati.
Can I ask one
Excellent.
question?
Yes,
Yeah,
ma'am.
Dr. Gauri, go ahead.
Please,
Yeah,
ma'am, but I am
like-
expert. Please.
Like if there is a hypokalemia in patients, especially who has undergone bowel surgery, should we estimate the magnesium level also? I mean to say, will supplementation of potassium along with magnesium, if both the levels are low, will it expedite the gut recovery in the postoperative period?
I cannot answer this question objectively, but to my little experience, I can say if the post-operative patient is inside ICU, the ICU itself explains the intensive nature of the care. So we are not going to depend and label the potassium depletion as refractory to initiate magnesium. Rather, you can beforehand check the magnesium level and we can replenish potassium and magnesium side by side.
Okay. I mean to say, in relation to gut recovery, this was the specific thing that I wanted to know. It's okay.
I cannot answer, madam. I'm sorry.
No, it's okay. But nice
Right,
presentation. Very nice presentation.
Thank you, madam.
After very interesting presentation and quick discussion, I hand over this session back to the organizers.
Thank you, sir. We appreciate the time and effort you took to prepare and deliver this excellent talk. I also thank Dr. Minu Chadda ma'am and Dr. Swati Chabra ma'am for moderating this session. As we come to the close of today's enlightening session, I would like to take this opportunity to express our deepest gratitude to all those who made this webinar a success. My heartfelt thanks to our esteemed speakers, Dr. Bhavna Rastogi ma'am and Dr. O.P. Sanjeev sir, for sharing their valuable insights and expertise with us. A big thank you to our moderators, Dr. Gauri Arora ma'am, Dr. Reema Meena ma'am, Dr. Minu Chadda ma'am, and Dr. Swati Chabra ma'am for expertly guiding us through today's discussions. A heartfelt thanks to Dr. Naveen Malhotra sir, Dr. Tej K. Kaul sir, Dr. Swati Chabra ma'am, Dr. Anil Kumar Verma sir for ensuring that everything runs smoothly. We deeply appreciate the time, effort, and energy you have dedicated to make this event a success. I would like to thank all our participants for joining us today. Your engagement and questions have enriched the discussions and made this event truly interactive. We hope that you have found today's webinar valuable and we look forward to hosting you again in future. I thank Dr. Naveen Malhotra sir, Dr. Vishal Singla sir, Dr. Anil sir for giving me this opportunity to moderate this wonderful session. Thank you so much.
I think everybody will agree that you were really a very good moderator. God bless you.
Thank you so much, sir.
Okay. On behalf of the RSCP, I thank our patron, Dr. THK Kaul, sir, for being there throughout the webinar on both the platform Zoom as well as YouTube, and blessing us all. And Dr. Naveen Malhotra, sir, President RSCP, for being the guiding light force behind all the RSCP academic activities. And I thank and congratulate Team Kanpur for conducting this wonderful webinar. And with permission, if we can close this webinar.
Thank you, Swati, for
Thank you.
being the patron today, and we will meet after a fortnight. Thank you very much.
Thank
Thank
you
you,
and
sir.
good night,
Thank you.
everyone.
Thank you, sir.
Thank you, ma'am.
Thank you, everyone.
Long live RSACP. Long live RSACP.
Long live
Long live
RSCP.
RSS.
Thank you.
Long live RSACP, sir. Hi, Shwati.
Hello, ma'am.
I'm Strawberry Swaika.
Hello, ma'am. How are you?
Hello, how are you?
I'm
Sir,
good, ma'am.
Sir, Naveen sir, कैसे हैं?